Good evening, everyone. Oh, we got a few more coming. Thank you all for signing in. I think everybody's got the habit of it now. That's great. And thank you, MCAT, again, for filming this. Has anyone looked at any of the lectures online? I have, and they're quite good, so if you're interested. Please fill out evaluations if you have a minute. We really appreciate it. It'll definitely determine any future presentations. Next week's lecture will be on the Eleanor project, and we have one after that, and I'm blanking on that, but we have two more left for the semester.
We're going to have a lecture by Rose Hill coming back from Guinea on her work there right now.
Okay, so two more excellent ones. Okay, tonight we have a terrific speaker. We have Dr. Abebaw from the University of Gondar in Ethiopia. He is the director of the Institute of Public Health at the University of Gondar. University of Montana has a collaboration agreement with the University of Gondar, and we hope that this collaboration is in a rapid phase of expansion and growth. And this is one of the early visits we've had. Dr. Abebaw has been here for nearly 2 weeks now and has not had time to do anything or see even the mountains here. He's been so busy, but everyone has appreciated his presentations enormously. He received his PhD in public health from Addis Ababa University in 2013. His areas of expertise include maternal and child health, reproductive health, family planning, and adolescent health. He has served as the department chair of epidemiology and biostatistics at the University of Gondar and the director of the North Gondar Zone Health Center team. I think we'll learn what zones are and what health center teams do, perhaps. Yes, a minute. He has numerous publications, book chapters, active research projects, and serves as an in-country expert consultant in these areas of his. I'm very glad to welcome him here. I would encourage all of you, if you can't understand him or hear him well, to please raise your hand, because his accent is a little different than a Montanan accent. It's better English than ours, but it's a little different. So I think it's just really important that we hear him and understand what he's saying. So if you see people waving hands, it means please repeat. Okay? Please, Dr. Abebaw.
Thank you very much, all of you. I am very happy to be here. Really, my university, the University of Gondar, has so many programs that can be linked with the University of Montana. And we have started many things in the area of research, academic area, as well as community service. So hopefully we'll have a very strong collaboration compared with any other universities. My presentation will be focused on the trends of maternal and child health indicators in Ethiopia. And I will have some brief introduction. And then I'll see the maternal and child mortality indicators, like under 5 mortality rate, neonatal mortality, maternal mortality ratio. And then I'll have also some indicators on morbidity, specifically the major causes of under 5 in maternal mortality. And I have also indicators on nutritional status, like stunting and underweight, and fertility indicators. I'll focus on total fertility rate, and service indicators like family planning, unmet need, contraceptive prevalence rates, antenatal care, delivery care by skilled providers, and the immunization coverage of Ethiopia. So these are the indicators I want to discuss in my presentation. The recent reports indicate that Ethiopia this time has about 100 million population, and under 5 population is nearly 15 million. And the total births per year is about 3,176,000. And under 5 deaths is about 184,000. This is just the statistical figures to introduce how much Ethiopia is the second populous country in sub-Saharan, in Africa, next to Nigeria. And there is a rapid expansion of private, for-profit, and NGO sectors in the Ethiopia healthcare system, which in fact boosts our health service coverage and the utilization through encouraging the public, private, and NGO partnership. And the health service received, revised, in fact, in 2010. It was a 4-tier system, but now we have 3-tier system. This means 3-layer system. And this is the system we have. If you see, we have the primary level healthcare system. In fact, there is variation between the urban and the rural. In the rural, we have the lowest level, that is the health post. This is basically a small clinic, usually dedicated to give preventive service like family planning, vaccination, and some treatments like diarrhea, malaria, and pneumonia. And many of the activities are more of preventive services at home and at health post. And this is staffed by 2 community-based health workers. We call them health extension workers. And health extension program works a lot because this is nearby the community. And it is dedicated to give a population of about 3,000 to 5,000 population. And we have, next to this, we have health center. This health center is designed to serve about 15 to 25,000 population. And in each health center, we have about 5 health posts. And the health center has laboratory, pharmacy. We have also outpatient department. In some cases, some beds for admission, and also all other preventive services like family planning, delivery service, antenatal care, everything. So this is the health center. And then we have now district hospital. We call it also primary hospital. And this is used for referral purpose, which includes cesarean section. All the services provided at health center will be provided in the primary hospital. So all of these things are known as the primary level health care or the district level health care. In the urban center, we have setups, we have health center. And they are a bit different. They have staffed with many, even in some cases we have general practitioners. But in the rural health centers, we have most of the time mid-level health professionals, meaning graduates. Nursing, health officer, laboratory technicians, pharmacists, and many others in the health center. And then the second level is a general hospital, which consists of many services like pediatrics, surgery, gynae, internal medicine. And it is expected to give this much, meaning 1 to 1.5 million people. And this is secondary level used for referral purpose for the primary level. And the specialized hospital is expected to give service for this much population, up to 5 million people. And this is a high level or a tertiary level health care with specialized services like ophthalmology, dentistry, sub-specialization services. So the University of Gondar has one big hospital. Currently, we are building extra buildings with about 1,000 bed capacity, very huge hospital. And in fact, the hospital is so busy, and our medical training is in this hospital most of the time. And in fact, we use health centers and hospitals around Gondar. So we have surgery, pediatrics, gynaecology, internal medicine, specialty trainings. And in public health itself, we have about 16 different specialization programs. So we have so many medical trainings in Gondar. Let's see the trends of these mortalities. Just to explain about this indicator is calculated by taking the total number of under 5 deaths per 1,000 live births in a year. This is a calculation. And this mortality rate indicator is well known, and this is the most important indicator in the world. And when you see the success story of Ethiopia, this is, if you remember, the Millennium Development Goals. Ethiopia succeeded to achieve MDG 4 ahead of the deadline, 1 year ahead of the deadline in 2014. So this is a rapid change from 2005 in 1990, and then it declines 166 in 2000, and 123 in 2005, 88 in 2011, and finally about 59 in 2015. This is mainly because of the changes in the post-neonatal period. Unfortunately, the change in the neonatal mortality is somehow slow. There are several reasons for this. One of the major reasons is most of the births are at home. And home births is very common in Ethiopia. Nearly more than 80% of the cases. I'll show you the delivery service in Ethiopia. So that is the reason why neonates can die because of asphyxia, neonatal sepsis, and in fact, low birth weight. These are the main neonatal causes I'll show you later. So the change is there, but the change after some period is sluggish. So there is a policy direction to focus on neonatal survival, on neonatal mortality. And maternal mortality ratio is calculated by taking the total number of maternal deaths. In this case, maternal death means death as a result of pregnancy and pregnancy-related conditions. And this is calculated by taking the total number of maternal deaths divided by the live, 100,000 live births. Because this is somehow rare issue or rare condition, usually the denominator is very big. So this is the way how we calculate maternal mortality ratio. We have another indicators of maternal mortality, like the lifetime risk. We have also the so-called maternal mortality rate, and we have also the maternal mortality proportion maternal mortality. So all the 4 indicators can be used, but commonly this is the main indicator used in the worldwide or as a global indicator. So what is happening? In 2000, around 2000, it was about 871. In 2005, there is some change. In 2011, even no change, somehow increasing. In 2040, in this recent report, there is some change. So generally, the change that is expected in MDG5, that is reducing maternal mortality by 3/4, was not achieved. So we are challenged to address this indicator. Anyway, in recent reports, we have some success story. Overall, there is some decline in all the indicators. So this is the area that we are doing a lot of things in Ethiopia. Another important indicator to see the causes of under 5 mortality here is, if you look, the neonatal related causes contribute the majority of the cases, nearly half of the cases, 47%. But the second main reason for under 5 mortality is pneumonia. We have now planning collaboration research with Montana University to understand why pneumonia is still a major problem. There is indoor air pollution. We have limited capacity to do analyze air toxins and also estimating the level of indoor air pollution. We have a lot of experience about this. Most of the time, our farmers use wood and dung as source of energy or fuel. And there is a lot of exposure. And the third one is, as you see here, there are other causes, sepsis, neonatal, and also other causes, but diarrhea, malaria, and other causes are becoming declining. But pneumonia is a main problem in under 5 still. When it comes to maternal mortality, the main causes here are listed. Previously, it was abortion, but because of the change in law about the safe abortion service, the contribution of abortion declines. It was nearly half of the causes of maternal disease is abortion, but now it reduced to about 10%. A main cause rather is hemorrhage, specifically postpartum hemorrhage, because many of the mothers give birth at home, and then they may not get help at the time of their birth. So that is the main reason why hemorrhage is the main cause of mortality. Now, the second major cause is becoming hypertension. This means pregnancy-induced hypertension, that is eclampsia and preeclampsia. So this is becoming a very important cause. And then puerperal sepsis, meaning sepsis in the postpartum period. We call it puerperal sepsis. And abortion still is important. There are indirect causes. Indirect causes is nothing but it is called illnesses or morbidities aggravated or induced by pregnancy. So this are example, for example, malaria become complicated during pregnancy. The main cause of mortality during pregnancy is pulmonary edema if there is malaria. Pulmonary edema is the most important cause of death during severe malaria. And in most of the sub-Saharan Africa, the main causes of mortality is also hemorrhage. This is the Ethiopia statistics. And when it comes to nutritional indicators, this is these are selected indicators of nutrition. And if you see the percent of children less than 5 years who are moderately or severely underweight, the indicator is this one, and stunted. Stunted means or reflects long-term nutrition deficiency and then long-term effects of nutrition deficiency, and usually affects the stature, and then you'll get short stature or the height with age will be affected, the most important indicator. So this indicates that it was very high prevalence in around this period in 1992. In fact, we have national statistics measurements, and that shows that stunting is very high. But there is some change in the socioeconomic development of the country at this time. Ethiopia is one of the country with good progress in terms of economy. And in 2000, it was about 57, and in 2005, 51, and in 2011, about 44. Now it is about 40. So there is a dramatic change in nutritional status in the population. So then the stature, over time, the stature is improving, okay? And this is a underweight indicator. Underweight is also somehow improved. Okay, it starts at this level, and now it is about 25%. So we have very good change even in nutritional status. And this is the total fertility rate of Ethiopia. Previously, the mother will have about nearly 5 to 6 children expected to give this much number of children. But because of very good family planning program in Ethiopia, the fertility rate is declining. It was somehow changed in this 5 years period, but later on it was very good. Now it is about 4. So we expect that the fertility rate will decline because contraceptive use is increasing. So there is a lot of change. And because of girls' education at this time, there is a strong pressure from the government that every child should join schools. And then after this strategy, many adolescents are now in high schools and in the universities. We have about 33 universities currently. We have only 2 universities. And in a short period of time, the universities are expanded. So we have about 23 million students throughout the country, yes.
Is there a big difference between the rural and the urban areas in fertility?
Yes. In urban area, in Addis Ababa, for example, it is less than 2, below the fertility replacement level. And in Amhara region, again, about 3, something like that, lower. There is regional variation and urban-rural variation. And we have such differences. I don't want to see the details, but yes, we have such differences. But the major change in fertility reduction is because of the change in the rural community. Because the rural community is about 85%. And small change in a big population is much more meaningful than a big change in a small population. This is very important logic. So there is some change in the rural population in the use of contraception, and also we observe changes in fertility. So this is because of the change in the rural community. This is contraceptive prevalence rate. You can link this idea with reduction in fertility. As you see here, the red color indicates that the demand, the unmet need, contraceptive, there is a lot of interest to use contraception, but the population who wants to use but unable to get or access contraception, this much number previously. But now the access is addressed, and then it declines somehow like this, about 25%. So then this means that we have still a lot of people who want to use contraception but no access. So this is known as unmet need. And we have a very good change in contraceptive utilization. We call it, this is a met need. So the CPR, contraceptive prevalence rate, is increasing from this 3%, nearly double 6%, 14%, 29%. Now it is around 36%. So this is significant change, and the family planning program is one of the successful programs in Ethiopia. So we expect the change will continue to increase in the near future. And the demand satisfied is calculated by taking the total demand, means met plus unmet need. It will be the denominator, and then the met need will be the numerator. So then this is the way how we calculate. So the satisfaction, meaning addressing the family planning demand, is increasing from time to time to reach to this level. And this is maternity service. I'm sorry, this is the one we are still behind when compared with other sub-Saharan countries. And the average use of antenatal care at least once is below half of the pregnant women. That means 60% of the pregnant women never see any help. Yes.
Why do you think?
Yeah, this is a big, a very important question. There are so many barriers. If you see especially the delivery service, it is less than 20%. So that means more than 80% of women give birth at home without any health professional. The main reason is road access is one. It's very difficult for some of the areas to get, transportation. In some areas, they use usually the traditional stretcher, and then they carry the mother on their shoulder and they bring to the main road. Currently things are changing. We are making all maternity service free without any charge. And there is also ambulance, at least one ambulance in each district. But the problem is they have no road to bring from the village to the main road. And when they come to the main road, sometimes they may not get transportation. Because of this, many women try their best or any other option at home. And if they fail, usually prolonged labor, and then if they fail, and if the labor is or the birth is obstructed, they will bring after several delays. And then the mothers usually come to hospital with a lot of complication. And fistula is a very common problem in our setup. So this is the main problem. There is a change, especially in the antenatal care, but delivery service utilization by health professionals, this means by skilled provider, is low still. But at this time, there are a lot of things are going on to support this program. And there are also other reasons like traditional practices, so they'll try. And also, in some places, peoples are mobile, nomadic population. We have a lot of nomadic population in the eastern part of the country and also southeast part of the country, and the Somalians and also the Ethiopian Somalis, and also the Afar area. And you will not get even the women easily because they have no permanent residence. They will move from one place to another place. And this is the immunization program. This is one of the, I am presenting the country average. Otherwise, there is again there is a lot of variation between regions, between rural and urban setups and so on. So the percent of children immunized against measles, and we have also hip vaccination. We have also pneumococcal conjugate vaccination. We have also DTP, this is diphtheria, tetanus, pertussis. And we have also rotavirus vaccine recently started here. This is very recent. And we have all this, and it is scheduled. Usually we start at birth. Initially we start with polio and BCG, and then it continues to have other contraceptives after 42 days. These are this first dose of this one, and then it will be repeated every month until 3 doses are completed. And we have also rotavirus at this time, and we have also the HIV and pneumococcal for prevention of pneumonia, recently included in the schedule of immunization programs. So there is a change. It was, it is around 20% like that. In some cases, even comes down. But after time, it is about 40%, even more in 1995 because of strong immunization campaigns and so on. But later, it was somehow delayed or declined. But after that, after 2000, it increases sharply. And nearly 75, like 76%, 70% of the children are immunized at this time. This is an average. But in our region, for example, it is more than 90% immunization. So there is a lot of change in immunization programs. So we have some good service indicators, again, in maternal and child health. And this is a challenge. I think you can appreciate how it is difficult. There are peoples here. There are villages here in this mountainous area. You'll get villages here. There is no access to the main road. So difficult to go. And sometimes so steep, and then you'll get difficulty to walk. And you have, this is a landscape. It is interesting. This is North Gondar. And in fact, you get also the peak in Ethiopia, that is Ras Dashin in the Samin mountain. So Mount Ras Dashin is around here. So you'll get that. And it is like this. So sometimes challenging to access service for this community living in these gorgeous and the difficult landscape areas. This is my presentation that I want to share about the maternal and child health, selected maternal and child health indicators. Thank you very much.
Will you take some questions?
Yes. Please ask questions. Any question? Yes.
I have a few. If you go back to the schema of the health system,
Yeah. Okay.
where will the private sector and the NGOs fit in here?
Yes. In fact, this is a government healthcare system. The private health system, there are private clinics, usually, and we have also private hospitals. So the private hospitals are usually in this area. There is no specialized kind of. So we'll have private hospitals in this place. So then sometimes they be used as referral centers. Most of the private facilities are concentrated in urban centers. So you will not get private clinics in rural areas or in the countrysides. In Addis, you'll have so many private hospitals that contributes a lot. And also in Gondar city, there is private clinic. And some of the private clinics are focused on one kind of service, like dental service or ophthalmologic services, or sometimes they will have a reproductive service, like that.
So in terms of addressing maternal deaths, there isn't probably a large role for the private sector. You're using the public health system to assure access to delivery. And you said you're stopping charging for deliveries.
Yeah.
Just now?
Yes, we have no cost for any maternity service at this time.
And that is recent.
Even we are trying to link the referral system with, ambulance, and then the community can call to the ambulance. But the problem is the mobile penetration in some places is very low.
Yeah.
And some of the areas are difficult to, transport women with complicated childbirth.
So in your list of maternal or neonatal deaths or maternal deaths, you did not name obstructed labor. Do you include that under hemorrhage? Or?
Number one. Obstructed labor?
Yeah.
Cause of maternal.
Neonatal death.
Neonatal.
Or maternal deaths, I'm sorry.
Maternal labor, okay, this one.
Yeah. I don't see obstructed labor.
Yes, it is here. It is here, included under. So the obstructed labor is here. For cesarean section, usually what is happening at this time is, just let me share you one important information. Most of the obstructed labors are now managed at hospitals. So the first indicator, more than 30% of admission of cases for cesarean section is obstructed labor. So most of the obstructed labors are managed in hospitals, but still it has a lot of contribution in our maternal days, so it is included here. Hemorrhage is number one cause of death because it will kill. A mother with postpartum hemorrhage can be died in 2 hours. And if there is no transportation or difficult to transport a mother from the rural area to the main road, and if it takes more than 3 hours, 4 hours, sometimes 6 hours, no way to support. So this is the main reason why hemorrhage is number one.
So you had said on the healthcare chart the levels. So if a woman has obstructed labor, she needs to move from like the health center up to the primary, because that's where you would have the C-section. Is that true?
Yes.
So no C-sections at the health center, right?
Yes.
Okay. Is that a strategy to think? So at the primary hospital, like training nurses to give C-sections? No, that's not a strategy.
Primary hospital, we,
Oh, is the doctor, okay.
the staff, this is a mid-level health professionals,
Okay, so-
undergraduates. At this level, we have gynae obstetrics people, and then sometimes trained for the GPs trained for cesarean section, or health officers, or the mid-level trained for cesarean section will work at primary hospital at this time. So some of the primary hospitals around Gondar, for example, are active, and they reduce the burden of cesarean section from the University of Gondar hospital. So they are handling so many cesarean sections in the primary hospitals. And this is, in fact, expected to even give other minor surgeries, major surgeries, in fact, cesarean section and safe abortion service, in fact, minor, and the appendectomy or emergency surgeries. They are doing these things there in the primary hospital.
Okay. I have two questions, and I think they're related. We know that Ethiopia is one of the countries that has been really affected by what we call the fatal flow of expertise. A lot of doctors, nurses have left Ethiopia and practice now in countries in Europe and here in the United States. My first question is, has that affected in any way the statistics and the care for maternal child health care? And the related question is, you know, the progress that's been made is impressive. And so I wonder if it has something to do with greater government investment in the healthcare sector. Has there been a change in government policy that has led to greater investment in healthcare, and why did that happen, if it did happen, and has that had any effect in restraining the fatal flow of expertise?
Yeah, you are right. There are so many policy and strategies were changed. Yet for the first question, yes, many doctors are leaving Ethiopia, you know, because of economic reason, and they usually go to the other African countries like Botswana. They left to US, Europe, and they have also, some are also to Middle East. And the training is very good, excellent training, and they are skilled, highly skilled professionals. Yeah, that affects somehow, but as a strategy, the government plans to produce so many health professionals or doctors in the country. So the medical education this time it was in 2 universities, in Addis Ababa, 3, Addis Ababa, Jimma, and Gondar. Now we have about 24 colleges to train doctors, medical doctors. And specialization programs were only in Addis. Now in Gondar, in Jimma, in Makale, in Addis Ababa, and even other places in Awasa. So we have now expanding the training program throughout the country. So the number of, or the ratio of physician to population is now improving. One, though there are flaws, there is some change. And the other thing is the government is expanding health facilities throughout the country. For your surprise, in the next 4 years, the government plans to build 800 hospitals throughout the country. In fact, we have already so many health hospitals. And the number of health centers before, they were small. In one specific zone in North Gondar, it is in Amara region, the health centers were about 10 or 20 like that, between 10 and 20. Now there are 133 health centers, and they increase access to this strategy. This layer, this primary, secondary, it was 6 tier. There was health station, then health center, and then the district hospital, zonal hospital, and that kind of referral link. To improve access as a strategy, the government makes, it was 4, from 6 to 4, and now 3 layers. This is purposely to increase access. Access is improved. And the other strategy is we have the health extension program. This health extension program, in fact, starts with this is done by the lowest level, the health post. The health post is a small clinic, usually provide preventive service, but they contribute a lot in the awareness creation, health promotion, sanitation, and also preventive service like family planning and also immunization and other activities. The health post is staffed with 2 community-based health workers, female community-based health workers. They have 1-year training, but employed by the government. And they work here at the health post, and they have now link with the so-called the Health Development Army. This Health Development Army is following the structure of in fact, it's derived from the army structure. That is a group of women, usually 5 in number, neighboring women, and 1 will be the leader. And they have discussion about their health every week. And then they have also cluster. These 5 women, again, have 30 women cluster. This is about 6 different small teams. And the 6 groups have 1 cluster, meaning about 30 women in the similar area, and 1 be the leader. And this leader has frequent communication with the health extension workers working here. And they have meeting every 2 weeks. They report morbidity, pregnancy, mortality, every important health event to the health extension worker. That makes the network effective. So the Health Development Army, Health Extension Program network contributes to improve access. And now the strategy works or contributes a lot. So we have a different approach compared with the previous time. The health extension program and also the health post and this strategy. Because of increment in family planning, what is happening? If there is family planning, maternal days will come down. If you use space, and if you reduce the number of births, automatically maternal health will be improved. And most of the deaths are associated with frequent births. And bleeding and postpartum hemorrhage complications are usually raised when there is frequent births and multiple births, like greater than 5 or grand parity. Having this much is very dangerous. The same thing for child survival. I have so many figures about these things, but so neonatal and maternal mortality or child mortality in general declined because of the family planning program, the health extension program, and the control of many infectious diseases. Malaria at this time is no more headache for Ethiopia. It is controlled. Nearly, it's more than, I think, more than 5 years, we don't have any malaria epidemic. So malaria is becoming controlled, diarrhea is reduced, and then the mortality is reduced. This is the reason why the indicators are coming down. There are so many other, a lot of strategies from the government. So these are the things I want to reflect. Yes?
16% of the maternal deaths were due to hypertension. Is hypertension a problem across the country? Is it increasing? And if so, what are the causes?
Yes, yes. You know, we have now the so-called double burden. Double burden means that we have the infectious disease and still problem, but chronic diseases are increasing. And there are so many changes in lifestyle and then many other things. dietary reasons, and so on, and also stressors. So the number of diabetic cases, hypertensive cases are increasing significantly. And this is also reflected in maternal health. In fact, preeclampsia, eclampsia is associated with the placenta factor during pregnancy. That, the reason is not well known, well defined. Anyway, preeclampsia and eclampsia is becoming common. In fact, any history of hypertension is always risk for maternal survival and also child survival. So the pregnancy will aggravate the complications of hypertension if that hypertension is not controlled. Very dangerous. Yes, it is increasing. Any more?
I have one question. So the
Yeah.
nomadic population, do they have any problems getting access to free delivery? Like, do they have the proper paperwork? Are they treated differently, or no problem?
Yeah, this is one of the challenges. The contraceptive rate is very low. Service utilization is very low in this population. The nomadic population usually, you can't get them easily. They live today here, and tomorrow they are in another place. And very difficult to follow whether most of our reproductive health programs require follow-up. You can't, and that is a challenge. And we are now thinking a strategy that will be suitable for the nomadic population. That is a kind of mobile clinic. Yeah, but the problem is, again, transporting this material. You need, again, transportation system, even in that area. So that is a difficulty. Though the landmark is very good in that area, it's flat in the nomadic areas in most of the time. But still, you have to have road constructed, and then you can go and you can think different services. But the problem is, they are not stable. They will go from place to place. Any more? Yes.
Regarding the underlying mortality,
Yeah.
you mentioned that 90% of child are dying because of diarrheal diseases. Particularly, my interest is about 8%, that's diarrheal disease.
Yeah.
What type of initiatives you have taken? What types of treatment for diarrhea you usually in Ethiopia?
Yes. In fact, this was about 20% 5 years back, before this report. And it is declined to this much. Changing the sanitation behavior and the availability of water and also treatment in the community changes things significantly. After having this health extension program, the community gets treatment there, nearby, from the health posters. And then the problem of diarrhea declined. But still, diarrhea is very important. The most important reason for this due to diarrhea is it is not the infection, it is the dehydration. So the dehydration is the most important thing. If you rehydrate a baby, no problem. So then we have ORS as a vital drug available at the community level. Sometimes we distribute to the households. So they have the ORS, they know how to prepare the oral rehydration salt. So this ORS is available and then distributed to the community. And it is presented or available at health post level. So then the days associated with dehydration is no more problem. Yeah. Yes.
I didn't understand why the antenatal care rate was increasing when at the same time the delivery unsafe, and let me say that, was also increasing. How can those two things go together?
Great. This is a good question, I think. Yes, always. This is, in fact, similar throughout the world, I can say. Antenatal care is a bit higher, but delivery care is always behind. There are two major reasons. Number one, antenatal care is easy to, during pregnancy, women can go by their own foot and they can get service. And usually you can plan. But in the case of delivery, you don't have time. It is always, delivery or labor is always an emergency issue. You can't plan it. It can happen anytime. So it is very difficult sometimes to travel because you need transportation system, you need other people to help you, and then usually occurs at night. You may say, why? This is due to the hormonal changes that happens that facilitates the labor usually comes during our sleep time. That's the main reason. So delivery usually happen at night and is very difficult, and then it happens suddenly, and then very difficult to move, to transport. The other reason is in most parts of the world and in our setup, delivery is expensive. You need to pay for transportation, at least if the service can be free at health center or at hospital. The problem is you have to pay or you have to arrange transportation. So sometimes it's not affordable for many people in the rural community. They can't unless they sell their land or their ox. Or that means very, big decision. So that is the main reason why this variation happens. It is almost happen everywhere. So antenatal is in a better position compared with delivery service. Yes, can add.
Second question is about the health system. When we see most of the indicators were increasing since 2010, what kind of policy the summary may be? Can say Ethiopia health system is using, that can be an example for other countries that helps you to increase all your indicators. Well,
Yes, you are. Yes, there are so many changes happened. In Ethiopia, there is a 20 years plan. We call it health service health service development plan. So we have five years totally, about 20 years health service development program. In this period, in the first period, there were a lot of observations that doesn't work were changed in the second phase. And again, the failures observed in the second phase were changed during the third phase. And now we are completing the fourth phase. And then after, many of the things were changed after the first phase. First phase was before 20 years. This was, I think, in 2005, like that, five years behind. The fourth phase will be completed in 2015, yeah. Now we have another 20 years plan, and there is always policy change. And the main change specifically is the health extension program, was really contributes a lot in reducing child mortality. I can say that is the main reason. And in fact, the training of many health professionals, mid-level health professionals, contribute a lot. So there are so many changes. And you can see, look at the health development program of Ethiopia. You can get all the phases, and you'll learn how government changes many of the strategies. Any more?
Yeah, I have another question regarding the essential medicine of your country, and particularly the oral steroid you mentioned. This is locally produced or this is imported?
Usually imported. Yeah, the oral contraceptives.
Oral steroid regarding the diary of the...
Oh yeah, it can be. Yes, that we have several direct factories in Ethiopia, so that can be produced. But others like vaccine, family planning, contraceptive methods, usually exported from where? From US, and in some cases from Europe. Any more?
Thank you very much.
Okay, thank you so much. Thank you.